with mortality rates reaching up to 80% in globally countries and up to 35% in the developed world. And the growth burden is also enormous. 896,000 deaths were accounted for emergency general surgical conditions, most common cause for which was the complicated peptic ulcer disease. So the treatment principles are fairly simple. The perforating segment forms the source of sepsis that has to be controlled, and then be adequately treated with appropriate antibiotics and be provided with supportive care in the form of nutritional support, respiratory renal support, etc. However, this entire process is prone to a lot of complications, and which are systemic and non-systemic, and thus render this entire process to be quite lethal. But it is also, so what is the recommendation for source control? So according to the Surgical Infection Society guidelines, the source control should be undertaken within 24 hours of diagnosis, and it should be undertaken in a more urgent manner when the patient is sick, and septic or in septic shock. But it is still prone to delays. The 3 delays model that was described 25 years back in the realm of veterinary mortality describes the first phase is being the one in which the patient has to decide to seek care. The second phase is the process in which the patient has to identify and reach a medical facility. And the third phase involves the patient receiving adequate and appropriate treatment when in the hospital. And all of these phases are also interrelated. So the applicability of these 3 phases is generally can be applied to all surgical conditions, and has thus been also adopted by the Lancet Commission of Global Surgery recently. Just a brief recap: the first delay being the decision to seek care, the process to reach care, and then eventually to receive the care. The first 2 delays in this study were grouped together to form the pre-hospital delay, which are reflected by the duration of presenting complaints, while the third delay is what is formed, which we term as the inpatient delay. So the pre-hospital delays. As is well described now, 5 billion people lack access to safe and essential surgical care when needed. And in certain regions, up to 97% of the population do not have access to timely and surgical care, these being Sub-Saharan Africa and certain regions of South Asia. So do they really matter in the context of alimentary tract perforation? Well, really not much is known despite these very huge numbers. Inpatient delay. So, as you all know, when the patient is received at the ER, he or she has to go through a battery of investigations, then receive initial appropriate treatment in the form of antibiotics and fluid resuscitation, and then we monitor the patient for response before eventually shifting the patient to OR. All of these stages and phases are again prone to delays, hence the great variation. But do these inpatient delays matter? According to the literature, some retrospective studies have found an association between inpatient delays and mortality. However, there are other studies that have also refuted these findings, so therefore it is really not that clear that inpatient delay is associated with increased mortality. So our question, based on this background, was, do preoperative delays have an impact on mortality in patients with alimentary tract perforation? And more importantly, we also wanted to see which of the 2 types of delays is associated with mortality, be it the pre-hospital delay or the inpatient delay. We did not really seek to identify the causes of these delays and really go into the details of what cause was resulting in these delays and their eventual impact. We wanted to simply see which type of delay is associated with mortality. So we conducted a retrospective cohort study at Assam University with cases spanning 3 years from July 2015 to 30th June 2018. We included all patients who had alimentary tract perforations and excluded all patients who either had traumatic or iatrogenic perforations or had anastomotic leaks. And we conducted all variables, collected all variables that were present at the patient's baseline state and not when the patient had presented to the ER. Our analysis was performed by STATA, and we performed a multivariable logistic regression as well as a Cox regression analysis to test for significance. We had 80 patients. Of these, 68 patients survived with and however 12 patients expired with a mortality percentage of 15%. The variables that we collected included age, gender distribution, height, weight, BMI, and to be really thorough with regards to the patient's baseline condition, we calculated the Charlson comorbidity index for each of our patients. And of these variables, We found that the patients who expired had a significantly greater age and had a higher charge to comorbidity index. The other variables that were included the time to the ER presentation, time it took from shifting the patient from the ER to the OR, the site of the perforation, presence of malignancy, and presence of fecal endocytes. And of these variables, the one variable that stood out was the time it took from moving the patient from the ER to the OR, being significantly greater and upwards of with a median of 16 in those patients who were expired. The time it took for the patient to reach the ER, which is the pre-hospital delay, was also greater. However, the difference was not significantly significant. The p-value was 0.19, hence this variable was included with the multivariable logistic regression analysis. We had 4 variables in this analysis, and of these 4 variables, the time to shift to the patient to the OR was found to be significant. However, the odds ratio was not that great. In multivariable Cox regression analysis, again, similarly, of the 4 variables, we found that the hazard ratio for shifting the patient to the OR was 1.015 with a p-value of 0.04. So, what does this really mean? Patients who had a longer inpatient preoperative delay had greater odds of mortality. And pre-hospital delay in this study was not associated with a significant effect on the mortality. Why? Well, in this study, we really have not sought to describe the causes behind these findings. However, we can hypothesize. Faster inpatient care may have conferred a significant survival advantage than any disadvantage that could have been conferred from the pre-hospital delay, or patients who had inpatient pre-operative delays were sicker to begin with, hence had a higher mortality, or pre-operative delay was detrimental. We really cannot pinpoint which was the associated factor in this study. So what is the way forward? We are conducting a larger study with a larger sample size with variables that will reflect the severity of conditions to really understand the third delay, which is the inpatient delay. And we also propose and plan to conduct a prospective study to understand the reasons for delay and their overall impact on other outcomes as well. Thank you.
Now I will invite Dr. Narayan from University of Cornell University to discuss this article.
Thank you, Dr. Khan, for that outstanding work. I commend you and your co-authors, Dr. Khan, for the continued excellence in work. Your dean, Adalheimer, is a dear friend of mine, so excellent work. When you talk about perforations of the alimentary tract, you mentioned it correctly, source control. You know, in trauma, I'm a trauma acute care surgeon, it's the right patient getting the right care at the right place at the right time, right? So those are the basic principles. So it's no surprise that if you delay that, antibiotics and fluids are adjuncts to care, that delay is going to be a problem. And so you mentioned a limitation that you didn't define the causes, and I think that needs to be your next step, because otherwise you'll never answer the question. I also was interested to see that your outcomes in terms of your patient to the ER time is 24 hours. Now, according to your slide, up to 24 hours. You show that again. Let me make sure I saw that correctly. In terms of your timing, is that right? Time to ER is 24 hours?
Yes, sir.
So, I mean, that is a long time for perforation. I don't even show it. And so, could you talk a little bit about this? As you're going to address this, and as low and developing countries are struggling with this in South Asia and abroad, time to access of care is going to drive your outcomes. Now, the 24-hour delay in getting the patient to the hospital is one. The in-hospital is much less. So, can you talk to me a little bit about how you're going to address the pre-hospital component? Thank you.
Thanks so much, sir. So with regards to your first comment, thank you so much for that very important comment. That is one of the things that we are going to conduct in the future as well, and really try to understand what are the causes that result in this delay. And surprisingly, it is not that well described in the current literature. It is a common and general understanding that, of course, if there is a delay, there is going to be a bad outcome. But even even with regards to the recommendation that you should perform any intervention within 24 hours or urgently, it does not clearly describe as to what should occur in that time period. Are there any resuscitation endpoints are we trying to achieve if a patient is spending any time in the ER? And if, for example, a patient A spends 6 hours and a patient B spends 8 hours, which is better off? So that is a very important point that we plan to address. And with regards to the pre-hospital delays, that is what is unique to the very vast majority of this world, which includes 5 billion people according to estimates. And this basic idea came from one of our other studies in which we had actually seen that patients who had undergone emergency laparotomies were presenting to our hospital from all over the country, actually from many hundreds of miles away even, for conditions that were included perforation and obstruction. And it's quite a complex problem. Barriers to access to surgical care include environmental factors, include patient-related factors, include their education, their understanding of their problem, their belief systems with regards to where should they be seeking care, should they be going to quacks, or should they be seeking care from religious healers, and then the infrastructure that exists out there. The road network, it has to be good enough. The transportation to the hospital, that is a problem. Most patients do not have any motorized transport. They would either transport via cars or etc. By other means. And then the financial limitations are enormous as well. So frankly, addressing them is the biggest challenge, because that is where the problem exists. And it is so multifactorial that there is no one easy solution. In the previous presentation, that is one of the solutions, that you can actually take surgery to those areas where they need the surgery the most, and that is one of those proposed solutions. But because
Thank you, Dr. Khan.
Yeah.
We are running short of time. Any more questions from the audience? So quick question. So the two common perforations that you get in your population are enteric perforation and gastric perforation, right?
Yes, sir.
So enteric perforation patients have to be taken back again and again because you suture them and then after 2 days they did new perforation, right? How many patients in your group have to go back for multiple laparotomies?
So in our study, our catchment population, the most common was the perforated duodenal culture. The enteric perforations, so there were patients who had to be taken to the OR, but frankly we have not accounted for that in this study.
Thank you.
Our next speaker is going to